What I want to talk about today is radiologic technology and what it means to be a radiographer or a radiologic technologist. I'm going to talk about different career pathways in radiologic technology. I'm going to talk about radiologists, and I'm going to talk about education requirements to become a technologist. First, I'm going to start with the names that people call us. I don't mean that negatively. We are radiologic technologists. That's a preferred name, and that is the name by which we are referred to professionally according to our professional organizations. Often we're referred to as rad techs, which is just a shortened version of radiologic technologist. Sometimes we are referred to as radiological technologists, which is a little bit more cumbersome to me. Sometimes we're referred to as radiographers, and where that comes from is obviously radiological, radiologic, but also what we do is we make images kind of like photographs. So it's kind of like radiology married to photography, so radiographers. And then sometimes you'll hear us referred to as some form of technician, either radiologic technician, radiological technician, x-ray technician, and none of those are the preferred or accepted terminologies. X-ray tech is kind of the layman's term for what it is that we do. We create x-rays. And then imaging specialist, even though it's a lesser known terminology, is probably a little bit more descriptive for people who don't really understand what it is that we do. So what we are not is a radiologist. A radiologist is an x-ray doctor. They go to medical school and they receive their MD, and their specialty is in radiology. So they read the images, make the diagnosis. A radiologic technologist is not allowed to make a diagnosis, even though you might see something that is glaringly obvious. You cannot make that diagnosis either in the patient's medical chart or to the patient themselves. You can present the information and tell the doctor what it is you think is going on with the patient, but ultimately it's the doctor's responsibility to make that diagnosis. We're not a type of nurse either. We have a totally different set of curricula that we have to follow in colleges to receive our education in radiologic technology. We're not a nurse. We're not a button pusher. There's much more to the creation of an image than pushing a button. Sorry. We're not lesser educated than any of the other medical professionals either. Our education is very, very much similar to in length and college hours as what a nurse or an RN, a registered nurse, is. So more so than an LVN and on the same level as an RN. So what we do primarily is we take care of the patient. We provide images and we assist in the diagnostic practice. But our primary job is to make sure that the patient is well cared for. Their safety is assured, and the patient that leaves the x-ray department is in at least as good a shape, preferably better than when they arrived. Certainly we want them to have that diagnosis, so we're going to provide the images to the radiologist, and the radiologist is going to take the images and try to make some sort of diagnosis out of it. In our education, what we have to know is pretty extensive. We have to have extensive understanding of anatomy, less so of physiology, but certainly of anatomy. We're making images of things we can't see. So we have to know where the patient's anatomy is most likely to be according to their size, their body build, and those sort of things. But we can't see for sure where those internal structures are, so we have to look at the external landmarks to give us some sort of idea where that internal anatomy is. We already covered patient care, but imaging physics touches three of the following. So we have imaging physics, image creation, and radiation protection. So what we use, we have to have a working knowledge of the equipment, so the function of the required equipment, so that we can manipulate the X-ray beam to be in the proper energy range with the type of x-rays that we create, the number of x-rays that we create. So I kind of stumbled through that, but what I mean by that is we have to adjust the machinery to create an x-ray beam that we have to understand its energy level so that we can know how it's going to interact inside of the patient, so that we know what the x-ray beam going through the patient, out the backside of the patient, and interacting with the image receptor is going to look like. So we have to know how to work the equipment to create the x-ray beam that we need so that we can have the proper dose administered to the patient, so that we can create the x-ray beam or the x-ray image that would best improve the patient's chances of getting a good diagnosis. So the difference between diagnosis and image creation are what we're going to cover in the next two slides. So what we see here are three different x-rays of two different patients with broken ribs. So I'm hoping that you can see the cursor. If not, I'm going to describe the image on the left. So there's a rib in the center of that image that if you follow it out from what looks like the spine out from the midline of the patient towards the side, you can follow the contour of that rib, and what you see is kind of a jagged edge where the rib stops, and then it drops down a little bit, and then it picks back up again. So that's indication the patient has a broken rib. Most sophomore students in an x-ray program can see that, but they can't tell the patient, you've got a broken rib. Even if the patient says, do I have a broken rib? I can feel it moving. The technologist cannot say, yes, you have a broken rib. So presence of broken ribs is not all that big of a deal. It's much more important to know what's going on in the soft tissue structures inside the patient's thoracic cavity when they have a broken rib. So what we see over here is less obvious fractures, but the patient has multiple rib fractures over here as well, as indicated by the multiple red arrows. What's going on underneath this patient is what we're seeing here, and you don't really see it in this, so this must have been a follow-up image later on, if indeed this is the same patient. So what we have here is, if you look at the patient's left lung, and this is the center image, what you see is the ribs, and then in between the ribs where things get darker, you kind of see these milky, squiggly lines, and those are supposed to be there. Those are lung markings. So with the lung markings being present, what you get, or what you should see this, but what you see over here is a complete absence on the patient's right lung, is a complete absence of those lung markings. That indicates that the pleural lining was punctured and we got air inside of the thoracic cavity but outside of the lungs where we don't want it in the thoracic cavity, and that caused the lung to collapse. The collapse of the lung is what we refer to as atelectasis. This massive area of foreign air is what we refer to as pneumothorax. So the lung being deflated is much more important to visualize than what the fracture of the rib is. So this could affect the patient's outcome much more so than just presence of ribs, fracture of ribs. So the fractured ribs are uncomfortable. If this continues to increase in size, what we may get is what we refer to as a tension pneumothorax. And that is where this pushes over and collapses the opposite lung, and now the patient doesn't have any fully aerated lung. And that's a bad day for the patient. So what we look for in an image is, in a chest x-ray like these, is we look for the top of the chest x-ray. So what we see, or the top of the lung, which is what we call the apex. Apex kind of like the top of a mountain. And then we've got this pointy thing down here at the base is what we refer to as costophrenic angle. So we have to see from the apex to the costophrenic angle. We have to see from side to side. So that's minimum. But we also need to look for rotation. And what we're seeing here, these two things are what we refer to as what you refer to as your collarbones, but they're more technically referred to as clavicles. So the clavicles kind of look like they touch the spine, but they don't. They're anterior towards the front of the patient, whereas the spine is posterior. So if we have any kind of rotation, what we're going to see is separation between the inside or medial portion of the clavicle and the spine. So it doesn't, one of them is going to look like they don't touch the spine anymore. So we're going to look from top to bottom. We're going to look side to side. We're going to look for rotation. We're also going to look for where these clavicles are supposed to come in, and they should come in right above this thing right here. And what that is the aortic arch. You don't see it quite so well over here. You do on this one, but it should be right above the clavicle should be right above the aortic arch. And what the arch is your aorta comes out of the top of your heart, and it makes a 180-degree turn to go down into your thoracic cavity and eventually into your abdomen. So what that arch is you're looking at where it turns, right? So it's my arms are the aorta and my hands are the aortic arch. You're looking straight down onto it like this. So it gives us that round appearance. It's not really, completely shaped like that. It's just that you're looking straight down onto it. So the clavicle should be right above that. So if we go to this next one, what we see is the aortic arch is here. It doesn't look the same as the previous one, and that may be because of the positioning of the patient. But what we see here, the clavicles are way up on the apex of the lungs. That indicates that the patient is slouching backwards like this. So this is poor positioning, and that may be why it is our heart looks so much different, or our aortic arch looks so much different. And sometimes we want a lordotic chest x-ray, but most of the time we do not. I assume this is portable, taken in the patient's room just because of this thing right over here. What these are positioning indicators. So this tells us that the patient was upright, and this tells us that this is the patient's right-hand side. So we look at x-rays as if the patient is looking at us, or at least chest x-rays and abdomen. So the patient's left-hand side is on our right, and the patient's right-hand side is on our left. So that's, the R stands for right, and erect means the patient was examined upright in some way. So very easy to get a lordotic chest x-ray on a portable patient. And I'll talk about what a portable patient is here in a minute. So this is not an ideal x-ray unless we're specifically looking for the apex of the lungs, which is probably not the case here. The education requirements for a radiologic technologist are an associate's degree minimum. There are bachelor's and master's degree opportunities. And then some of the modalities, and I'll explain what modality means here in a minute, but some of those require further education as well. Most have a separate registry or board exam, but not all of them come with formal education requirements. So one thing that I get quite often is, are x-ray programs difficult? Well, they're challenging, but they're doable. So I'm going to link this video in the notes below, but there are different types of educational programs. Most of the programs I'm familiar with are what we refer to as selective admissions programs. So you have to have certain things in order to qualify for application. And then the selection is based on your credentials and how well you did in those prerequisite things. So the better your test grades are, the more likely you are to get into the program. So most of the students who get into an x-ray program have the credentials to get through. It's just, are they going to spend the time and study and learn the information? Some of the students, this is very science-based, and some of the students are going to struggle with that. So some of the students just, they can't focus on the science portion. But most of the students who get into an x-ray program have the capacity to get through it. It's just a matter of applying themselves. So yes, it's challenging, but it is doable. There are a lot of clinical hours required, and clinical hours are the hours spent in a hospital with patients. So I really recommend that you do some research on the programs, do some research on the requirements of the program, do some job shadowing in a hospital before you commit yourself to 2 years of education in a program that you're not real sure what it is that we do. And that applies to pretty much anything that you're trying to get into, whether it be healthcare or something else. So do put a little bit of research into to know what you're getting yourself into. And when you do your job shadowing, ask the technologists that you work with or the personnel that you work with what they think about the education. So the settings in which we work in a hospital or out of the hospital are really pretty diverse. In the hospital, there are a lot of different opportunities and a lot of different things that you can do. So radiography is creation of x-rays, just like the chest x-rays that we saw previously. Fluoroscopy is also done in the radiography department, but it is more like a moving x-ray. I'll link a fluoro exam in the notes as well so that you can see what it is that I'm talking about. Likely you have seen a fluoroscopy image or a fluoroscopy exam in your health class in school, or if you've taken biology or something like that. And what a fluoro image is where it looks like a skeleton is eating a sandwich. And it's not a cartoon, it's an x-ray. So it's a real person chewing on something, and you can actually see moving x-ray images, and that's what fluoro is. We do a tremendous amount of our work, probably 30 to 40% of the work comes from the emergency room, either in the form of chest x-rays and abdomens, or skeletal work, broken bones and things like that. So we do a lot of trauma. We do portables, and portables are where we will take a machine up to a patient's room and perform an x-ray at bedside if the patient is too sick or unable to come to the x-ray department. We always get a better image with the patient in the x-ray department than what we do if we go to the patient's room, but sometimes that's not feasible for the patient to come to the x-ray department, so we go to their room, take a portable chest x-ray or abdomen most of the time. Mobile sounds like portable, but it's not, and it really shouldn't be under the category of hospital. Those are typically done outside of the hospital. So a mobile service goes to remote locations to take x-rays rather than having the patient go to the emergency room. So if a patient is in a nursing home and they fall in a nursing home and the staff in the nursing home thinks the patient's okay and didn't break anything, but they want to be sure, then they will call one of these mobile services and order an x-ray, and the mobile service sends a van out that has a portable x-ray unit inside of the van, and they'll take x-rays on site and then send those images to the radiologist for interpretation. So it's not the same thing as portable, even though they use portable equipment. One thing that surprises students in a lot of cases is the amount of time or the number of resources we commit to surgery. If we have a patient, for example, that has broken their leg and they have to have it surgically repaired, before the patient leaves surgery, they want to make sure all the screws are in the right place and the bones are lined up properly so that they'll heal right. So what we may do in surgery is have a fluoro unit working with the doctor directly during the repair to make sure that everything lines up properly, or instead of doing that, what we may have is just a regular x-ray before they sew the patient up and make sure everything is in the right place. So that's surgery. And then we've got doctors' offices and clinics. We do, some doctors' offices and clinics do have their own radiographers on staff. So career options. In the video I referenced before that I'm going to link into the notes, there is a limited licensure in a lot of states that allows you to practice and make specific x-ray images. It's not a full license. So if you're thinking about applying to a program, I can't stress enough how much you need to ensure that you know what kind of program you're getting into, if it's a limited licensure or full licensure. So a full licensure allows you to pursue all those opportunities I'd mentioned before, plus what I'm about to as well. And the modalities. With modality that I referenced earlier, what the modalities are different imaging techniques. So in X-ray, in an X-ray department in a hospital, what we have are a lot of different ways that we can image the patient's anatomy or physiology. And each one of those comes with its own benefit, the things that it sees best. And that entire set of imaging techniques is what we call medical imaging. So X-ray is a technique for medical imaging, as is computed tomography. You may have heard this referred to as CAT scan. CAT scan is an archaic term. We don't really use it anymore, but computed tomography is a way to image internal organs and reconstruct them in a way that x-rays cannot. There's some confusion between images between CAT scan and MRI, but there are some similarities as well. The images look very similar. In both cases, you can image patients' brain, lungs, internal organs, but where you see magnetic resonance really shine is in imaging soft tissue. X-rays don't image soft tissue as well as MRI does, and CT uses X-ray beam. CT images soft tissue much better than what radiography does, but not as well as magnetic resonance. So the downside of magnetic resonance is that it doesn't image bone as well as CT. So both of them are very, very good at what they do. Bone densitometry, excuse me just a second. Bone densitometry is just as the name suggests. It is a technique that we can use to assess the mineralization of a bone and how dense the bone is. So if a patient has osteoporosis, then we can determine about how much of the bone that they've lost in the process of their disease process of osteoporosis. Nuclear medicine studies physiology much better than what most other imaging techniques do. Interventional radiography are things like cardiac catheterization or special procedures where we're looking at very, very small anatomy, specifically blood vessels. And mammography is, of course, breast imaging. Ultrasound is another imaging modality, and some of these modalities can be learned on the job, like computed tomography and magnetic resonance, bone densitometry, and interventional radiography don't necessarily require formal education. There are programs that you can attend and might make it a little bit easier to get your credentials or your licensure in those modalities, but it's not absolutely necessary. Nuclear medicine, mammography, and sonography are going to require, and radiation therapy are going to require higher education. There is a license required. It's a national license through the American Registry of Radiologic Technologists, but some states require a license as well. So some of your states will have a dual license. State of Texas, we have the ART license, but we also have an MRT, which is Medical Radiologic Technologist license, and that is through the Texas Medical Board. There are continuing education requirements. They're 24 hours every 2 years. That sounds a little bit arduous if you have a state license as well, but your state license for the most part is going to accept what you submit for your national license as well. So you don't have to get 48 hours every 2 years. Almost universally, your 24 hours that you would submit to the ARRT would satisfy the state requirements as well. So things you need to know before getting serious about applying to a program is, number one, it's not like on TV. We don't stand behind a piece of glass and make an image. We don't push a button and magically something happens. That portion of the job comes after a lot of other tasks that you have to do. You may have to physically position the patient in order to get the images that you need to see. Some of the patients are going to be very difficult to deal with because they can't cooperate, so you're going to have to physically put them into position. So it can be very physically demanding. Dealing with people who are injured or sick is always going to be stressful. So this is not unique to radiologic technology. Anything in medicine is potentially going to be very stressful. But since the patient sometimes can't cooperate with what we need them, the position we need to put them in, we have to use a lot of critical thinking to use the equipment to compensate for the patient in a lot of cases. We also have to use critical thinking to assess the patient's condition before we make the x-ray so that we know how to adjust those parameters that I was talking about before so that we can use the proper amount of radiation and the proper energy levels. So it takes a lot of creativity and flexibility. Self-motivation, you're going to be working either by yourself or with somebody. So you have to be a self-starter to be successful. Work alone or in groups. Exposure to blood and body fluid is just a fact of life. A lot of people will try to pursue radiologic technology because they think that nurses deal with much more blood and body fluid, and that's just not true. We deal with compound fractures, shootings, knifings, a lot of things. So any kind of work in a hospital, if you're working in a hospital in a larger town all the way up to a city, there's going to be shift work and call required. Radiation exposure is unavoidable. The type of radiation that we use is much like light. It's just very, very high energy light. So there's no way around it. You're going to get exposed sooner or later. But we do teach you the proper ways to limit that radiation exposure. But if you're afraid of radiation exposure, it's going to be a challenge for you. So the technology changes constantly. Since I've been in diagnostic imaging, the image capture alone has changed 3 times with completely different technology each time. But the flip side of that is that there are a lot of opportunities in the imaging department, and that kind of takes us into, is it worth it? And the answer is yeah. So this is a career field that's probably not ever going to go away. So once you train in it, you've got the fundamentals and baseline to kind of spread out into different portions of medical imaging. Even if diagnostic imaging, diagnostic x-rays, radiography is kind of put on the back burner and not used as much as what it used to, CT, MRI, nuclear medicine, all those other modalities are not going to go away. So you have the opportunity to cross-train. You have the opportunity to have different jobs periodically throughout your career. Opportunities for advancement also exist into administration. We have presidents and vice presidents of hospital systems that started out as diagnostic radiographers off of a 2-year degree. Most of those opportunities are going to require additional education as well, but it's a good place to start. Please like, share, and subscribe. It's a free resource to bookmark, refer back to if you get into a radiography program, share with classmates. If you comment, I'll try to respond. I'll welcome suggestions on any topic. My next video should be how to be successful in your college classes. I'll link all the videos I discussed in the notes on this video. Thanks for your time.